Hello everyone. So here I am with the next video. So today we will be covering next pages, and I was thinking maybe we would cover more pages today. Let's see how we go. All right, then prophylactic, empirical, and directed antimicrobial therapy. So they have strategized the antimicrobial therapy into three parts. First of all is the prophylactic antimicrobial therapy. So it is the antimicrobial therapy that you will prescribe to the patient probably 1 hour before the procedure to prevent any infection when there is a significant clinical risk. Like, for example, if the patient is at risk of infective endocarditis, in certain cases, you need to prescribe the antibiotic. And surgical antibiotic prophylaxis is usually not required for common, like for uh, other than infective endocarditis, for the normal surgical antibiotic prophylaxis, like for the any normal procedure, like if the patient we need to take the tooth out, so it is not very commonly used to prescribe the antibiotic 1 hour before the procedure. But there are certain situations, like if the patient is immunocompromised, like immunocompromised means end stage liver disease, end stage kidney disease, HIV patient, or any other patient whose immunity level is down, sometimes we may need to prescribe him the antibiotic for the common procedures also. So we will be studying all this in detail in the next chapters. Then the empirical therapy, it means that the patient has established infection. So you are, but the pathogens are not being identified. Like, you do not know which pathogens are causing the infections, like for example gram positive, gram negative, anaerobes, aerobes. So you do not know, but the patient has infection and you need to prescribe, like what we commonly use, like amoxicillin, we just prescribe to the patient without testing him, like which microbiology, without doing the microbiology test to identify the organism. Antimicrobial choice is based on the clinical presentation and the expected antimicrobial susceptibility of the most likely or important pathogens. So, review empirical therapy. So, you need to review the patient as soon as possible. In hospital, patient review therapy daily. If the patient's diagnosis exclude any infection, then stop the antibiotic. If a pathogen is not identified, reevaluate, like is there still a need to prescribe the antibiotic, or always de-escalate. It means if you are giving the patient IV antibiotic, move it to the oral one, or from the broad spectrum to the narrow spectrum. If a pathogen is identified, then start prescribing him or start giving him the directed antimicrobial therapy, which will directly act on the organism which is the cause of the infection in that particular patient. Is used to treat an established infection when the pathogen has been identified. And an antimicrobial with activity against the pathogen can be selected. Preliminary microbiology results, for example, gram stains, may all allow targeting of the antimicrobial therapy before definitive results are available. Modify ongoing therapy once the pathogen and susceptibility are known. Choosing the route. Now we know types of antibiotic. Okay, so now the routes. From in the routes, there are certain routes how we can give the drug to the patient. First of all is the oral and enteral therapy, which is the most commonly used. uh, Oral therapy is usually associated with less serious adverse effect than the parenteral. Like, it is because, like in parental route, we do prescribe like the higher dose, right? It also has the advantage of lower drug and administration cost. Its cost is also lesser than the parental therapy. The antimicrobial listed in, like, these antimicrobials have very good oral bioavailability. It means if the patient would take it orally, it would be absorbed like nicely. Like, for example, clindamycin, doxycycline, metronidazole, trimethoprim, and sulfamethoxazole have and can often be given orally rather than IV, provided they are appropriate for the indication, they have adequate tissue penetration, and the patient can tolerate oral administration. For children unable to swallow tablet, the availability of a suitable drug formulation can affect antimicrobial choice. Okay, so with the children, you all know that they do not really take the tablets because they do not know how to swallow it. So they generally, it's for them it's suspension that we commonly use, and sometimes for some antibiotics the suspension is not available, so this can affect the choice. If the oral route is unsuitable, then the enteral route, we can try the enteral route, which means the nasogastric, nasoenteric, or endoscopic may be used. And the second route is the parental therapy. It means that you can give the patient antibiotic through IV or through IM route. When we use this parental therapy, like most commonly we always prescribe the oral thing, right? So if we know that the oral administration is not tolerated or not possible, then only we prescribe the parental route. Or if the GIT absorption is likely to be significantly reduced, for example, if the patient is doing vomiting, or his stomach is unable to, and he's unable to absorb the drug, so then also we commonly give them the parental route. And oral antimicrobial with a suitable spectrum of activity is not available. Higher dose then can be easily administered. If we really need the higher doses of the antibiotic, then the parental would be good one. Or we need the urgent treatment. For example, if there is any patient of cellulitis or Ludwig's angina, so we need to give the antibiotic as soon as possible. So in those cases, the parental therapy would be the best one. If parental therapy is used initially, reassess the need for ongoing parental therapy daily, because the parental therapy is generally be given in the hospital condition, right? So they will review it daily. Unless high tissue concentration or prolonged parental therapy is required, switch to oral or enteral therapy once the patient is clinically stable. So always look for the signs, like if the patient is getting stable, or if the fever is going down, if the signs of infection is going down, then you can always de-escalate the antibiotic. Guidance on when to, here they have given the guidance when you need to switch the antibiotics from IV to oral. For example, if you are seeing that your patient is clinically improving, the fever is resolving or improving, no unexplained hemodynamic instability, and he can tolerate oral intake with no concerns about malabsorption, a suitable oral antimicrobial with the same or similar spectrum or an oral formulation of the same drug is available. For children, a suitable pediatric formulation is available. Does not apply to infections that require high tissue concentration or prolonged intravenous therapy. So these are the things that we commonly use, but there are certain infection that does require high tissue concentration or prolonged intravenous therapy. So in that cases, not really. We can switch them to the oral. So the other routes are the topical, but we do not really use this route because there is a very high chances of getting resistant. and can cause hypersensitivity reaction. So the best route is the oral, and which is more commonly used. And if the patient has infection or if we cannot swallow oral antibiotic, then we choose to give him parenteral. Okay, so tips for optimizing the antimicrobial dosage regime. When selecting a dosage regime for antimicrobial therapy patient, there are certain factors like first of all the patient factor, then the drug pharmacokinetic and drug pharmacodynamic properties, and the drug interaction. We need to like clear in our mind with these four things before prescribing any antibiotic. In certain patients with altered pharmacokinetics, altered drug clearance, or volume of distribution, dosing can be difficult and expert advice may be required. This is not really important as a exam point of view, but you can read it. There are certain cases like if the patient has septic shock or severe burn or I'm sorry, patients with fluid sequestration and cystic fibrosis, pregnant women, and obese patients. For them, we may need to change the antibiotic doses, but this is not a really very important topic as for the exam. Okay, so monitoring of antimicrobial blood concentration is used to improve efficacy and minimize dose-related toxicity of drugs with the narrow therapeutic index. Monitoring may also be used to optimize dosage regimes in other circumstances. Okay, so choosing the duration of antimicrobial therapy. So first we read about the types, then route, then the duration of the antimicrobial therapy. The duration of the therapy for some indications is based on clinical practice because it is not clearly defined from the published studies. In general, use the shortest possible duration of the therapy consistent with the condition being treated. If antibiotic therapy is necessary for dental infections, a short duration of therapy is usually sufficient because the key component of management is dental treatment. So they always say this thing that the best treatment for any dental concern or any dental problem is the active dental treatment, and be it like antimicrobial or any other painkiller, they are only um, as additional therapies. They cannot help totally to the patient with the infection or with their pain. However, there are certain indications that require prolonged therapy. So you just need to understand that examples of dental indication for which a short duration of therapy. So if they ask you for how long you need to prescribe the antibiotic, it should be less than 7 days, which mainly you will read in the doses in this book which they have provided. It is mainly 5 days, but you should remember that it should be less than 7 days, the antibiotics. So, in which cases you will prescribe the antibiotic if there is any spreading odontogenic infection without severe or systemic features. Secondly, if there is any infection following dentoalveolar surgery, it means post-surgical infections and necrotizing gingivitis, NUG. So in these cases, we do prescribe antibiotic, but that should be less than 7 days. And prolonged duration of antibiotic therapy is associated with, and why we do not prescribe the antibiotic for long duration, because that can lead to increased risk of adverse reactions, clostridium difficile infection, candidiasis, and selection of antibiotic resistance, as well as increased cost. So all for the duration, we will be prescribing for less than 7 days, which is 5 days. Okay, and why we do not prescribe for the longer time? Because of these risks. Okay, then types of adverse effects of antimicrobial. Always consider benefit versus harm. therapy. Even you are prescribing painkiller or antibiotic, always consider how much the benefit of prescribing this antibiotic to the patient as compared to the harm. Okay, then, and discuss the benefit and harms of the therapy with the patient. Always involve the patient to make the shared decision. Explaining the harms of antibiotic therapy, adverse effects of antibiotic include diarrhea, rash, or more serious hypersensitivity reaction. Then antibiotics can disrupt the balance of bacteria in the body, the microbiome. While the consequences of this are not fully understood, it can cause problems ranging from mild yeast infection to more serious infection like Clostridium difficile. Antibiotics can also cause bacteria to become like bacterial resistance, and it can change the microbiome and make the patient prone to getting these infections like thrush or the Clostridium difficile infection, and can cause hypersensitivity, diarrhea, rashes. So you need to explain these things to the patient when you will prescribe him the antibiotic. So they have divided the adverse effects into two parts. First of all is the direct and then the indirect. Directly, what the antibiotic does to your body is always check if a patient has a first of all, before prescribing any antibiotic, you should confirm with the patient if they have any allergy to any antibiotic. Before prescribing an antibiotic, adverse drug reactions to antimicrobials are most commonly non immune related. They are pharmacologically predictable. For example, I think for every drug, the nausea, vomiting, these are the common side effects. And for the antibiotics, it can also cause the diarrhea. And the other immune mediated non-severe delayed reactions, like sometimes some rash can occur on the patient body, although that is not very dangerous, but it can occur. And however, occasionally the reaction is a severe or life threatening immune mediated, like that is the anaphylaxis, or the delayed, which is the drug rash with eosinophilia and systemic symptoms. Steven Johnson syndrome, toxic epidermal necrolysis, and subsequent exposure to the drug could be fatal. So they have divided, like in the direct, the what the antibiotic can do to your body directly. First of all, the pharmacologically predictable reactions, that is nausea, vomiting, diarrhea. Then the immunity based, there are two types. One is dangerous and one is not dangerous. The dangerous one would be the anaphylaxis and all these reactions, but the non dangerous would be only the rash. Then the indirect adverse reacts effects. So it is mainly the effects which does happen if the antimicrobial has gone inside the body, include effects on both the commensal and how does it change inside flora and inside environment, and that could lead to these effects. For example, Clostridium difficile is a common cause of antibiotic associated diarrhea. The and GIT can become colonized with. So you just need to understand that in indirect adverse effects, it can cause the diarrhea, they can cause candidiasis, and they can even increase the risk of resistance. And there are certain the risk of colonization and MRSA has been correlated with the frequency and the duration of prior antibiotic therapy. Particularly, the risk is from the quinolones and cephalosporins. The microbiome is an ecological community of commensal symbiotic and pathogenic organisms found in and all multicellular organisms, including human. So it's basically that when antibiotic goes inside your body, it changes the environmental flora, and that can increase the risk of diarrhea, candidiasis, and the resistance. Then what is the importance of antimicrobial resistance? What is antimicrobial resistance? Unlike other drugs, the use of antimicrobial in one patient can influence future efficacy in, like, for as I have told you before, like antibiotic resistance is not only a person problem, it is a community based problem. So that's the reason where they are very particular about this thing. The development and spread of antimicrobial resistance is a major problem for society. In the general sense, antimicrobial resistance means that an organism has either natural resistance to that antibiotic or they have acquired by continuously getting exposed to that. Although the mechanisms are complex, resistance usually develops due to selective pressure exerted by the widespread presence of antimicrobial drugs in the environment together with the facilitated transfer of organisms. The concept of resistance also applies to laboratory antimicrobial susceptibility testing and reporting, where a categorization of resistance implies likely to fail treatment with the antibiotic. These are not very, important lines. These are just theoretical line, but they would just want you to understand that antibiotic resistance is a very serious issue, and we should not be prescribing antibiotics where there is no need to. Antibiotic resistance is increasing in many pathogens. Emergence of resistance to reserve antibiotics. Like these are few antibiotics that they have given here. So they says that to these antibiotics, the resistance is emerging. For example, quinolones, carbapenems, vancomycin, and colistin. Antimicrobial use and emergence of resistance. Appropriate antimicrobial use delays. If you will use it properly, the resistance would not be there, right? And minimize the prevalence of resistance after it has emerged. To ensure that antimicrobials remain effective for treating important infection, it is crucial to reduce inappropriate antimicrobial prescribing, particularly of beta lactamase inhibitor combinations like amoxicillin and clavulanate. So they are asking you to reduce the inappropriate prescribing of these drugs: amoxicillin plus clavulanate, cephalosporin, quinolones, carbapenems, and vancomycins. Then, to deal with the antimicrobial resistance, they started this process which they call as antimicrobial stewardship program. So it is the program that promotes optimal, in through this program they make sure that the antimicrobial prescription is optimal. The aim of the antimicrobial stewardship program is to improve patient outcome and to reduce any adverse consequences associated with the antimicrobial use, including antimicrobial resistance, toxicity, and unnecessary costs. So they just need to make sure that you are prescribing the antibiotic to that patient where there is a need and prescribing optimally to reduce any adverse consequences. Antimicrobial stewardship is an important strategy for preserving the effectiveness of the antibiotics that are currently available in the face of rising antimicrobial resistance. Evidence shows that antimicrobial stewardship activities can reduce inappropriate antimicrobial use, which is associated with the improved patient care. So, describes standards for safe, high quality care of any person who receives antimicrobial therapy. These standards applies to prescribing in community and hospital settings. So they implemented this strategy into various level, like on the hospital level, on and the community level, and even at the dentistry level as well. So these things are not very, you know um, important as for the exam point of view, but you should know that there is this strategy where they help understanding the dentist that you should not be prescribing the antibiotic to anyone. And in, like, for example, efforts to avoid antibiotic use for infections when the likelihood of benefit is low. When the benefit is low, then you should not be prescribing, or selection of a narrow, always use narrow spectrum antibiotics over the broad spectrum antibiotics where possible, because narrow spectrum would only kill that microbe which is causing the infection in the patient's body, rather than suppressing other also. Okay, so managing antimicrobial drug shortage. All right, so these are the certain strategies they have named here. You can have a read about them, but not very important according to exam point of view. But you should be very, very careful if they ask you any questions regarding the antibiotic, because they are very fussy about antibiotics. Okay, so this is it. Maybe we can cover these few lines as well. So patient resources to promote and appropriate use of antimicrobial. And PS Medicine Wise has developed patient information about the appropriate use of antibiotics and antibiotic resistance, and discuss the benefit and harm of the antimicrobial with the patient. So always tell them about the harms that we read in that box, explain to them, and then make a shared decision before prescribing any antibiotics to the patient. So next time we will cover the antibiotic hypersensitivity part, which is also an important topic. Okay, so we are done for today, and hopefully you guys are liking the videos. And all right, so I'll see you all in the next video. Thank you so much for watching.